Good afternoon. I'm so happy to have this opportunity to talk to you. And thank you for overviewing those issues, Bill. My work, I'm a clinician, I'm an internist and pediatrician. I see adults and kids, and my work grows out of my experience in the clinic and trying to get out in the community and work with kids and families. But now I'm also learning that we do for the heaviest kids, we need to get them back into the clinical setting, especially to get treatment. So I'm delighted that we are recognizing this and you're starting to work on this. This picture was drawn by one of the little girls at the Woodlawn Community School. It's our partner school on the south side of Chicago. And the kids they all drew pictures of the Power Up program, and they voted and they picked the one they liked the best, and we put it on lunch boxes and t-shirts and so forth, and they really made it their own. What do I press? Okay, good. Okay, so Chicago's south side. This is a picture of the city of Chicago. Bottom half is the south side. There's just over 1 million people on the south side. University of Chicago is sort of right in the middle of the south side of Chicago. Primarily African-American patient population, especially around the university. We have very high rates of obesity and diabetes and complications. So again, practical and real-world solutions are needed to this problem. So I started several years ago. We did focus groups, we did interviews with school leaders, church leaders, focus groups with kids and families to figure out what were they doing currently, what do the kids do after school, what do they like and what do they want. And we started by working with the YMCA on the south side and the co-op food market in the area and put together a healthy nutrition and exercise program for overweight African-American kids and their parents who were working with them. We had good experience there. They were working creating recipes, doing physical activity. Nutrition Jeopardy in the lower left corner, and the two young ladies in black are the leaders. They were both undergrads at that time at the University of Chicago, and they have since gone on to become physicians themselves. And then shopping and looking at the food labels and so forth in the store. So this was a very heavy population. We recruited kids over the 85th percentile, but they were really all quite obese. Their BMI on average for 9 and 10-year-old kids was 33. So this program showed that we could successfully engage the kids and families. The lay leaders were great at doing that. The goal setting, the activities worked well, but unfortunately in this heavy group of kids, we did not see changes in their BMI or their BMI Z-scores. We also found out more about working with community partners. Our relationship with the Y was mainly that we were placed. We worked with them in sort of a client relationship and did not really engage them as partners. So I wanted to learn how to do better partnership. And then we also started to think about schools. I was warned early on not to work in schools because the schools have such a challenge and they have all their own agenda. But more and more we are coming to some common agendas, and in particular the after-school settings seemed to be a time and a place where there was room for programming. So we started working with Woodlawn Community School. We were introduced by another community member that we were working with on some other things. Woodlawn is one of the Chicago public schools. It's designated as a community school, and these schools are open beyond the regular school day to provide services into the afternoon for the kids and families. The kids who attend the school either live in that neighborhood or the families can apply to go there. This picture is Dr. Donovan Davis, one of my colleagues, and she's working with Principal Emble. Mr. Emble is from Ghana, and he is, I would say, an extraordinary leader. He's very charismatic and very interested in good programs and good products for his constituents, the kids and the families. So this relationship grew up over a year and a half, actually, before we actually started to do research, and that did help us tremendously in terms of ongoing sustainability and the partnership. So things we did to build that partnership, Donovan and I attended PTA meetings. We met with parents to figure out were they interested in this, what did they think about it. We worked with the teachers. Once it appeared that there was interest in doing a nutrition and exercise program together, we brought the curriculum that we had used in the former Reach Out program, looked at it with the teachers to figure out what would be feasible in their setting. And they know how the kids like to learn, what they like to do, what the flow of after school is like. We worked with the staff. So this gentleman in the picture is Mr. Hubbard, and he is the security officer at this school. And that's not who you would think of when you're thinking of putting together a program. You think first of the principal, of course, maybe the teachers. But Mr. Hubbard was really the key to doing a whole lot of what we wanted to do. He literally had the keys to everything. If we needed the video machine, he had the key to get that out of there, and he knew all the kids by name. And so if we were, looking to track one of them down to, double check some weight or something, Mr. Hubbard knew all the kids, and everybody related to him. So he was a very, very good partner. And so he's there with one of the T-shirts from the program there. And so again, we went back and forth. We worked a lot with the teachers and the other stakeholders to get a program that was going to fit and be really theirs. And we also shared some of the, the pilot grant funding we had with the school. So this program was adapted from that Reach Out program. The Reach Out program, drew from several sources. We looked at the Adult Diabetes Prevention Program. We looked at programs for kids, Planet Health, other programs that were out there. We did, as I said, our own focus groups and so forth. So we had that Reach Out program for 9, 10-year-old kids. We adapted it here, with the teachers for use in this setting. And initially, they wanted us to work with the kids all the way from kindergarten up through 6th grade, which was quite challenging to adapt it for those younger non-readers. More recently, we focused again back on that 3rd and 4th grade level. But we did adapt it and try working with the kids of all the ages by age groups. We had a curricular expert to look with us again at the different content and the age-appropriate lessons, and work closely with the teachers on that. So all the after-school kids participated in the curriculum. We had a pilot program, and we enrolled some of them as subjects. So we used in both the Reach Out program and then in this program the lay health leader model. The leaders of the program in this setting were the teachers. So they are lay in the sense that they are not medical professionals, and they're not usually about the business of helping kids and families move towards behavior change. But they are very knowledgeable about the kids and families. They worked with us and the behavioral psychologists on our staff to prepare for leading these sessions, and there was continued support for them throughout the program. And here you can see 3 of them. Lori McClinton-Powell is up in the upper left, and she's been a great partner. She's just very enthusiastic and engaged and creative, and has come with me to conferences both in Chicago and elsewhere to talk about it. Oh, and there are issues of trust. When we first started this, I said it took a year and a half to develop this relationship. One of the teachers asked me at the very beginning, well, who's getting their PhD out of this, And we talked about what's in it for all the stakeholders. And nobody at that time in particular was getting their PhD, but we talked about what we were interested in, seeing, doing. We talked about academic credit for it, how we could share that, and what things did they want, and what did they want for their school. The data collection was very pragmatic, very user-friendly. It was collected on-site, and the kids' families didn't have to go anywhere else. It was at school. We decided not to use blood in this study. We did in the Reach Out study. We had families come into the CRC to get glucose tolerance tests, but this was a very low-key and easy to do in the regular flow of after school. We had medical students who came and helped us, and the data that we collected included height and weight for kids, so BMI, and also for the parents. When the parents would come at pickup time to pick up the kids, we collected that data, as well as blood pressure for kids and parents, and then very simple self-reported measures on dietary intake, physical activity, and knowledge and beliefs and attitudes. So there's 70 children in the after-school program. Our pilot program only aimed to enroll 40, that's what we thought we needed for a pilot. So once we got up to 40, we actually quit recruiting formal subjects. The people who were enrolled, the kids who were enrolled in the program were, all the school is entirely African American. And we had 16 boys and 24 girls in the program as subjects. They ranged in age from 5 to 12. And then the parents were invited to be participants also. 28 parents were involved. This is because of the 40 kids, the moms had more than one kid. Some of the moms had more than one child there. They were all women who chose to participate. And this is the little girl who drew that picture I showed you in the beginning. So she's the logo contest winner, and she's very happy there. And that's the dietitian, Marla, who worked with us to help bring this whole thing off. At baseline, half the kids were overweight or obese, and this mirrors the current data for Chicago Public Schools and many other urban areas. We did see changes in BMI. This is actually BMI Z-score shown here, and it's broken down by weight categories. So there was a decline overall in BMI Z-scores. This is over a 16-week time frame that we did a baseline and then a follow-up after 14 to 16 weeks of the intervention. The changes were most pronounced in both the normal weight and the overweight group. So the normal weight kids, they were not losing weight, but they were growing, and then they came down within that normal range. And the overweight kids also modulated in a positive direction. The obese kids, over 95th percentile, did not move significantly. And so this is what makes me think, similar to that reach-out group, which was very heavy, that those kids need an additional, more medical and intensive supervision and intervention. So some challenges and limitations. This was a small study with short-term follow-up. It was from one school. It is a public school, but I told you, the people there are, I consider them extraordinary, and they're great partners. But again, generalizability, we need to work further on how to do that, and we didn't use a control condition. I've mentioned about the heaviest kids. And the other challenge that we found was that the parents couldn't come. This is after school. So the reason the kids are in after school is because parents are busy. So we had to figure out a better way to engage the parents. We had discussion groups, but they couldn't make it most of the time. So if you were going to engage parents and they're not there physically, how would you get to them? What would you do? Yeah, email. What else? When you want to check with your buddy, what do? You text them. Okay. So that's what we decided to do, and that also is something that was already, embedded in the culture of the school. So this is a, lower income community. Everybody had cell phones, and there's data on this nationally. Cell phones are pretty ubiquitous, so they're being used for all kinds of interventions, including at the University of Chicago. My colleagues are doing this with patients who have diabetes, adult patients with diabetes. And this is an automated texting program. You put the messages into the computer. The patient can specify what time they prefer to get them. I don't get up at 5 a.m. I want my message at 10 a.m. Did you check your feet? Did you take your medicine? And at Woodlawn Community School, they were already using this too. This school got the Chicago #1 First Day Attendance Award a year and a half ago. And they got it because they texted all their parents. They said, school starts tomorrow, be here. And they won this award. So we adapted that for use with this program. We sent messages to the parents twice a day. We sent them several different kind of messages. Some were just awareness. USDA Food and Activity Pyramid was discussed, or informational, 5 servings of fruits and vegetables are recommended. These were cued to what we were doing, in the power-up sessions after school. We had some behavioral suggestions and recommendations, include 1 fruit or veggie in each of your child's meals today, and then also questions. Like, what kind of exercise did you do with your child? And they could answer those. And they did like this a lot. So here's what happened. We had 10 families in this part of the pilot about the texting. They were very comfortable with texting at baseline. And then when we texted them questions, they often texted back more than half the time within 5 minutes. So they liked that a lot. It was part of their culture, and they liked doing it. They said it was very easy to use. It helped them to be in touch with what the kids are doing in school, and it helped to make them make some changes for their families. So the things are ongoing at this school. We are not doing active research there right now, but they have put in equipment. They've put in playground equipment, greenhouse. They have a school newsletter on fruit and veggie of the month. There's a produce van that comes weekly, and the families can buy produce. So they really have made this their own, and it is ongoing. This was just serendipitous. The White Sox and the University of Chicago made a partnership to work together on social marketing around childhood obesity, and they decided to use Power Up as a cornerstone of that program. So we actually now at the White Sox games on Sundays, we have booths set up for healthy nutrition and exercise activities, and kids can go online and it's almost like Girl Scout badges. They do activities, and then they can get some prizes. So that's fun. And that was at the school. I brought the White Sox and the players and the big mascot, that's their big green mascot. I brought it to the school. Again, this is something that, it's something that they like and that they get out of it, which is valuable. So here's some of the bottom line lessons. We got to build on the existing culture that's out there. What do people like to do? What are they comfortable with already? How can we use that? Texting and other technology can be used to help people integrate this into their daily lives. The heaviest kids, I think, do need more intensive care, and we need to make those connections back between our community organizations and our clinics. And then also, these partnerships can lead to policy changes. So I've been doing this for 10 or 12 years, and then I was asked to be on a task force a few years ago on vending machines, the Chicago Public Schools vending machines. And so our relationships, through these community partnerships can also help to move policy. And as we heard earlier from Tracy today, there's lots of policy that's converging in this direction now. So that helps us as clinicians and as community organizations to work together and get on board with this. Here are some of, this is my last slide, I think. Here are some of the policies that I'm thinking about in terms of, that are aligning. USDA Healthy Schools Challenge, Chicago Public Schools Wellness Initiative. When I started 10 or 12 years ago, I told you people said, don't work with the schools. But now the schools are on board with this. They have a Go for the Gold campaign, so it's in the schools' interest. They get recognition. They get, that's good for them as well. And so we are starting to work together, and we are aligning incentives. Chicago Department of Public Health has a whole citywide Healthy Chicago initiative. So this makes it, better, more fun, easier to do this research, and it is the kind of research and programs we need to connect our clinical arenas and our community and workplace and school settings. Here's lots of folks who contributed to and supported this. This was supported by a CTSA Pilot Award. And that's it. Thank you very much.